guys, I'm Sound from Inspiring Minds, and let's discuss about the very important group of drugs most commonly used in clinical practice and has a wide variety of application. Which are those drugs? Beta blockers. Yes, as you can see, beta blockers. What are beta blockers? Obviously, they are adrenergic antagonists. Adrenergic antagonist means blocking the adrenergic neuron, which receptor, blocking the adrenergic receptor. So it is beta blockers, mean it is blocking the beta adrenergic receptors. Let us recall where are the beta adrenergic receptor present. Mainly beta 1 on the heart, yes, beta 2 on the smooth muscle of the lungs, beta 2 on the blood vessels that are supplying the skeletal muscles, and even the smooth muscles is again beta 2, smooth muscles of what we say the uterus. Yeah, so beta blockers are blocking the beta receptors. So we have classified them into two categories again: non-selective and the selective beta blockers. Non-selective and the selective beta blockers. So non-selective beta blockers mean it is non-selective in action. It can block both type of beta receptors. That is, it would block beta 1 also and beta 2 also simultaneously. So the examples should be remembered, and let me tell you, because beta blockers are easy to remember. Why? Because they have a specific ending. Most of them are ending with o lol, o lol, oh lol. For example, I told you in the last video that the alpha 1 antagonists, they were ending with ocin, prazosin, yes, doxazosin. So these beta blockers are ending with o lol, o lol, o lol, o lol. So we should remember the non-selective beta 1 beta 2 antagonist. So most famous non-selective beta blocker is your propranolol, then we have nadolol, then we have timolol, then we have carteolol. The action is that mostly the propranolol and the nadolol, they have action mainly on the simple what we say cardiovascular system and your lungs and the bronchus and the smooth muscles. But the topical solution we have, drops of timolol and the carteolol are used. So we put these eye drops of timolol in the eye, and what does it affect? How does it affect the eye? That this timolol decreases the synthesis of the aqueous humor from the ciliary body in your eye. Yes, we know ciliary body is producing aqueous humor, and if the aqueous humor is not able to drain in the canal of Schlemm, what does it cause? It causes the glaucoma, development of the glaucoma. Yes, so timolol is used for the treatment of the glaucoma. Okay, so timolol is used in the treatment of glaucoma. Why? Because it decreases the synthesis of the aqueous humor in your ciliary body in the eyes. Okay, so this is the application of timolol, and same happens with the carteolol. But remember that these beta blockers are not the first line of drugs for reducing the intraocular pressure. For example, a patient is suffering from the glaucoma and he has a very very high intraocular pressure in the eyes. So at that point of time, it is not beneficial to give that patient beta blockers. Okay, we will use the drug that is a cholinomimetic drug, what we call as pilocarpine. So pilocarpine is the drug of choice for immediate lowering of the intraocular pressure that is caused due to the pilocarpine, for immediate lowering of the intraocular pressure that is caused due to the glaucoma. Yes, but once you have lowered the pilocarpine, then the patient may be put on the beta blockers for chronic glaucoma, so that there is reduced secretion of aqueous humor by the ciliary body in the eyes, and the pressure and the intraocular pressure is low. Then we have selective beta blockers. Selective means either it is going to block beta 1 or it is going to block beta 2 receptor. So let us study, or let us memorize the beta 1 antagonist. Yes, two of them are starting with the alphabet A: atenolol and acebutolol. Then metoprolol, this is one of the most important. Metoprolol, anybody asks you what is the non-selective beta 1 antagonist, first answer metoprolol. Anybody asks you what is the non-selective beta antagonist. First answer propranolol. So metoprolol, propranolol here is very important. Okay, so let us memorize: beta 1 antagonist, atenolol, metoprolol, acebutolol, and then we have the nebivolol. Remember that nebivolol is starting from the alphabet N. Okay, and it also causes the increased synthesis of nitric oxide in your blood vessels. Okay, so if the nitric oxide is synthesized in your blood vessel occurs, so what is going to happen? The nitric oxide binds to the endothelial cells in your blood vessel, and this causes the peripheral vasodilation. The blood vessel dilates in the periphery, so very good for the lowering of the blood pressure, because it is lowering the total peripheral resistance by dilating your blood vessels. Also, because it is beta 1 antagonist, it will block the activity of the heart, or it will lower the cardiac output. So again, very important group of drugs, beta 1 antagonist, that is very important in management of the hypertension, cardiac arrhythmias, and other cardiovascular problems. Then we have other type of blockers, that is beta 1 alpha 1, very important drugs, carbidiol and the lebitalol. Remember, the carbidiol is the only beta blocker that is not ending with olol. Okay, so it is the carbidiol. The mechanism of action is beta 1 alpha 1 antagonist. Okay, now we'll study about the propranolol, that is non-selective beta blockers, blocking both beta 1 and beta 2 receptors. So let us study about the propranolol. Obviously, beta 1 receptors are on heart. So the cardiovascular application of the propranolol is what? It depresses the SA node and the AV node. We know the SA node and the AV node, they have the beta adrenergic receptors. So it is binding to the beta adrenergic receptor in SA node and AV node. So it is, this drug propranolol is decreasing what? Depressing the AV node activity and the SA node activity. So the impulse transmission that occurs from SA node to AV node will be what? Decreased, and the cardiac output will decrease. Inotropy, what we call the negative inotropy. Then we have the negative dromotropy, that is conduction will also decrease from SA node to AV node, the electrical impulse that travels. So it depresses the SA node and AV node. So what will be the result? The frequency of heartbeats will decrease. So for example, heart was having beating earlier at 120 beats per minute, now it is beating at the 72 beats per minute. So that is how the frequency of beats are decreased. Also, the volume that is the heart is ejecting into the blood vessel, it is also decreased. So the stroke volume also decreases. Okay, so what is happening is that this is the one of the application. The other thing that happens with propranolol or other beta blockers also is that decreases the workload of the heart and decreases the blood oxygen demand of the heart myocardium. We know the myocardium of the heart, it is taking what? Oxygen from the coronary arteries. Now if the heart was pumping very rapidly earlier and you administer the patient with beta blockers, now the heart is pumping slowly. So myocardium is doing less work. Less work means it requires less oxygen. So the oxygen demand of heart is also reduced by beta blockers, and this is the application of the beta blockers because we are using them in the angina pectoris. Okay, angina pectoris, it is the temporary reduction in the coronary artery, the oxygen level temporarily reduces and that causes the chest pain. So what you have to do in such case is that you have to give beta blockers to the patient so that the oxygen supply or oxygen demand of the heart is reduced and the heart is able to pump the blood into the circulation without demanding much oxygen. Okay, so reduction of oxygen demand that is produced due to the action of beta blockers is used for the treatment of the myocardial ischemia and the angina. Myocardial ischemia, also we have the clot in the coronary artery and the myocardium is ischemic now. So ischemic means it is getting no oxygen or very less oxygen the myocardium is getting. So what you have to do is you have to make sure that the heart, that or the myocardium, it is not using too much of oxygen because already it has less oxygen. Okay, so again beta blockers will reduce the oxygen demand and thus can be used for the treatment of myocardial ischemia and the angina pectoris. Okay, also remember that once the myocardial infarction has occurred in the patient, and for example this was the myocardium and this area is infracted, means this is the necrosed area of the myocardium that has undergone death. This is the area that is still functional. Okay, patient was safe, patient didn't die of this myocardial infarction or the heart attack. But next time, once the patient has recovered, he has been discharged or he was operated for the myocardial infarction in the hospital, you have to give that patient beta blockers as a prophylactic agent for the prevention of the second heart attack. Okay, because for the prevention of second heart attack you have to give the beta blockers to that patient, so that in near future, whenever the ischemia is occurring to the myocardium, the heart is not demanding that much of oxygen from the coronary arteries, or heart has reduced oxygen demand. So because of the reduced oxygen demand of heart, the next myocardium ischemia or the next myocardium infarction, if it occurs, will not be of that much extent. Okay, so this is the application that it is used for prophylaxis for the second heart attack. And it has also been seen that this infarct that was previously formed because of the first myocardial infarction, if you give the patient prophylactically or if the patient is taking the beta blockers, the size of infarct is also seen to reduce. Okay, so it is preventing the myocardial ischemia also, and it is also reducing the size of infarct in the myocardium if it was previously present. Okay, then I told you that it depresses the AV node and the SA node, so it can be used for the treatment of supraventricular arrhythmias. Supraventricular means above the ventricular. If there is abnormal activity, electrical activity in the AV node or SA node, so or overactivity of AV node or SA node, so you can give the beta blockers and it will depress the activity. So it can be used in supraventricular arrhythmias, and also for the migraine because it acts centrally and have some beneficial effect in the treatment of migraine. The other importance is the hyperthyroidism. In hyperthyroidism, what happens is the general sympathetic activity of the body is increased. Okay, so beta blockers obviously will prevent the palpitations in the heart that has occurred due to the hyperthyroidism because of increased adrenergic activity on the heart. So it's the use. We have known the use, but the most important of them is side effect of the beta blockers, or the events in which you have to be very careful with your patient before you are administering your patient the beta blockers. Okay, for example, side effect is, first of all, side effect is your asthma, COPD and the bronchoconstriction. Okay, patient with asthma came to you, he is having the high blood pressure, and you gave that patient what? Beta blockers, non-selective type, that is you gave the patient propranolol. Obviously the heart rate will decrease because the propranolol will block the beta 1 receptor on the heart, but it will also block the beta 2 receptor in your lungs, and it will cause what? Constriction of your bronchus, and the patient is already asthmatic and he is having the bronchoconstriction. Maybe the bronchoconstriction can be very severe and this patient may die of asphyxia. So please take the history of the patient, whether he is asthmatic or not, whether he has a history of COPDs or not. Do not just give any patient non-selective beta blocker if you are suspecting the hypertension in the patient. Okay, so never use in asthma, COPD. Okay, then first side effect is that the initially because of the beta 2 blocking activity of this propranolol, the beta 2 blood vessels that are supplied by the beta 2 adrenergic receptor, it is blocked. Okay, and this results into initial vasoconstriction in the blood vessels, especially the blood vessels that are supplying your skeletal muscles. So initial vasoconstriction is there. Okay, and you should be very much clear that the patient who is having the high diastolic pressures, okay, you should not give them beta blockers immediately because of initial vasoconstrictory activity of these beta blockers. The pressure may even rise and make the situation worse. Okay, then the other side effect is the hypoglycemia, because we know that the normal sympathetic activity, it increases what? Glycogenolysis and gluconeogenesis, and increases the glucose level in the blood in normal sympathetic stimulation. Beta blocker is blocking this sympathetic stimulation, so there will be reduced level of glycogenolysis and glyconeogenesis. genolysis and gluconeogenesis. Because of this, there can be reduced level of glucose in your blood because of beta blockers. So if the patient who is diabetic and he is taking insulin therapy, and on top of that you prescribed him beta blockers, he can have severe lowering of glucose level in the blood, which may precipitate what severe hypoglycemia, and because of severe hypoglycemia he may lose his consciousness. Maybe he can die if nobody is able to assist him. Okay, or maybe he was sleeping and in the morning severe hypoglycemia occurs and he dies. So be very careful. Okay, diabetic patient, do not give non-selective beta blockers such as propranolol. So this is the mostly side effect of non-selective beta blockers. But so when can we give, which type of beta blockers can we give when we are only suspecting the hypertension in the patient do not have anything else? Okay, for example, beta 1 blockers can be given to asthmatic patients also. Which beta 1 blockers? Atenolol, metoprolol, isbutolol. Why? Because it is beta 1 blocker and it is blocking the activity on the heart, sympathetic activity on the heart, but it is not doing anything to your lungs. So these beta 1 blockers are safer to give in the patient with asthma, and also safer to give in the patient with any type of COPDs. Okay, so this is the application of beta 1 blockers. Can be given in which cases? Can be given in asthma, COPD, can also be given in insulin dependent diabetes mellitus, because the gluconeogenesis and glycogenolysis, it is beta 2 dependent and not beta 1 dependent. Okay, so it is safer if you want to give beta blockers. Then the other type of other group is the beta 1 alpha 1 blockers. Example, carvedilol is the example. It is very good drug, carvedilol. Why it is very good drug? Because if the patient is coming to you, he is having tachycardia, on top of that severe total peripheral resistance was found in the patient. Okay, severe peripheral vasoconstriction was found, so the patient is going to have very high systolic pressures and diastolic pressure. So by blocking the beta 1 activity on the heart, you are reducing the heart rate, you are reducing the what we say stroke volume, cardiac output also. And by blocking the alpha 1 receptor that are present in the peripheral blood vessels, you are causing the vasodilation. So it makes the pumping of blood by the heart easier and more efficient. So the carvedilol can be used in the patient in which there is less response to the beta 1 blockers, or they are not responding to the propranolol. So these drugs can also be used. So this is the application of the beta blockers that are commonly used. Main area of use of beta blockers is mainly the cardiovascular related area. Mostly it is used by the cardiologists and other doctors. Thank you for listening the videos, and please subscribe the channel.